Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues and friends, hope that you are all doing well and safe. Welcome back to our sessions. Today's session will be about a very important topic, which is teaching the mechanism of normal labor. Actually, this station was a repeated station before in the face-to-face examination. In the past 2 or 3 years, during the time of COVID, and because of the Osler online examination, this station disappears from the exam because it depends mainly on teaching on probes and mannequins. So it was not applicable to use or to appear in the Osler online examination. But now, because from the next exam, all will be going to face-to-face examination, so this station is one of the highly expected station to be repeated again in the exam. Actually, also it is, I'm sorry to say, it will be a shame for anyone who's working in obstetrics as an obstetrician and he will not know what is the mechanism of normal labor. It should be one of the granted station. You should go for this station and you are sure that you will do well in this station. Today together, we will show how to go through this station. We will mention what is the mechanism of normal labor, and we will give some few notes about the abnormal mechanism of labor in different malpositions and malpresentations, because if it will not come as a pure station about the mechanism of labor, you may be asked about these points in a labor ward priority station or in a structured discussion about any patient who's in labor with delayed progress. So let's start by our station today. About it will be a teaching station about the mechanism of normal labor. Here you will be an ST5 and you are asked by your junior colleague, the foundation year 2, he asked you to teach him the mechanism of normal labor. You will be provided during this session with a doll, a pelvis, fetal skull diagram showing the fetal skull diameters. All these are provided to you to help you in the teaching process. Please, in any station, when you find any probes or mannequins or diagrams are allowed, please don't forget to use these probes, because if you will not use it because of the stress of the exam, it will be converted into a lecture and it will affect your mark in the communication with the colleague. Okay, so here the agenda is written clearly. You need to define what is the mechanism of labor, and you need to teach the foundation year 2 what is the mechanism of normal labor. He's asking you to use the probes provided to facilitate the learning process, and you will answer some questions that may be raised by the foundation year 2. Before going into the mechanism of normal labor, we should know what's normal labor. Normal labor, it has 10 criteria to be defined as normal labor. If any one of these criteria is not fulfilled, this cannot be considered as a normal labor. So normal labor is a spontaneous expulsion of a single viable full-term baby in vertex presentation through the natural birth canal within reasonable time, without aid except episiotomy, and without fetal or maternal complication. So 10 criteria to define it as normal labor. So if the labor was induced, it is not normal. If it is twins or more, it's not normal. If the baby is IOFD, even if delivered vaginally, it cannot be considered as a normal labor. Preterm or post-term babies are not considered as a normal labor. Any presentation other than the vertex is not normal labor. Of course, if delivered by cesarean section is not normal, and if it is precipitate labor or prolonged labor, so the time is prolonged or the time is rapid, so it is not a normal labor. Any aid provided by the birth attendant, except episiotomy, will not be considered as a normal labor. And if there is any fetal or maternal complication, it will not be considered again as a normal labor. So this is the definition of normal labor. But what is asked here as a first step in your agenda will be the definition of the mechanism of labor. So you have to differentiate between normal labor and the mechanism of normal labor. What is the mechanism of normal labor? When you want to define it, you can say it is a series of movement undergone or undertaken by the presenting part, which is the fetal head, in vertex presentation as it passes through the maternal pelvis or the birth canal. So this is the difference in the definition between normal labor and the mechanism of normal labor. So the mechanism, it is a series of movement undertaken or undergone by the presenting part while it passes through the maternal birth canal. As in any teaching station, please follow the same steps. You will go by introduction and making a rapport and check the bullying. So you can say, hello, I'm Surur, and always please don't forget to start and end the teaching station with a big smile. He's your colleague. So you should encourage him by your attitude, your body language during the station, and your facial expressions. So remember, in any teaching station with a colleague, you have to start with a smile and end with a smile. Introduction, hello, I'm Surur, the ST5 in the labor ward today. And you will say, for example, I'm Sam. So hello, Sam, nice to meet you. How are you doing today? How things are going in the department? Now I'm checking for bullying. Do you feel supported? Is everything okay? How's your training going so far? All these phrases you can use. So after this, you have to explore the aim of the discussion. So Sam, I came to know that you want to learn about the mechanism of labor. Is that right? He will say yes. Now you have to put an emphasis on the importance of the topic whatsoever will be presented in the station. So here, the mechanism of normal labor. So why the mechanism of normal labor, Sam? He will say, because I need to know more about the physiology of normal labor, because I'm new here in the department. Here you will encourage him. You put some emphasis on the importance of the topic. You can say, you are right, Sam. It's essential for each health professional providing antenatal or intrapartum care to understand what is the mechanism of normal labor. This will allow complication to be recognized early, and this can help to prevent serious sickness. So this is a way to put an emphasis on the importance of the topic. Now check the background of the trainee and ask him, what do you know about the mechanism of normal labor? Usually he will say, I know some few information from the medical college, but I need to know more. So you will take him through your agenda. And here in the station, the agenda is written clear again. The mechanism of normal labor, you have to define it. You have to take him through the steps of the mechanism of normal labor using the probes and mannequins provided during the station. So the agenda will be, okay, Sam, so let's be organized. I will tell you today what is the definition of the mechanism of normal labor. Then I will take you through the steps of the normal labor. After that, I will show you on the mannequins and the probes we have today. And by the end, I will give you some useful articles and videos from Strategy. You can go through it, and we can arrange another discussion if you want. Please, Sam, at any point you feel that you do not understand anything or you need more clarification, please don't hesitate to ask me to stop and repeat it again. Is that okay? Yes or no? Now, Sam, the mechanism of labor is a series of movement undergone by the presenting part, which is the fetal head, in vertex presentation. As we are talking about the normal labor, so the presentation here will be vertex. Any movement taken by the head during the passage of the birth canal, it will be considered as part of the mechanism of normal labor. Sam, before starting the steps of the normal labor, let me tell you some briefly about the diameters of the fetal head and the fetal pelvis. So the fetal head here, it will have an anterior fontanelle, it is called the bregma, and another posterior fontanelle, it is called the lambda. Okay, okay. So there are some transverse diameters and some longitudinal diameters. The most important transverse and the largest transverse diameter of the head is the biparietal diameter. The longitudinal diameters, there are so many diameters here, but in normal labor, as we are talking about the normal labor, the diameter in full flexion of the head in vertex presentation will be the sub-occipitobregmatic diameter, which is 9.5 centimeter. It extends from the middle of the bregma or the anterior fontanelle to the undersurface of the occipital bone. Am I clear so far? Yes or no? Now you can ask him a simple quick question. So what is the presenting the diameter in occipito-anterior position? He will say the sub-occipitobregmatic diameter, which is equal 9.5 centimeter. Encourage him. Excellent, Sam. Well done. Then now go to the maternal pelvis. Sam, the maternal pelvis, usually it is heart shaped. It has an inlet and a cavity and outlet. The most important diameter in the inlet is the transverse diameter, which is 13 centimeter. It is larger than the anteroposterior diameter, which is 11 centimeter. Sam, this will be reversed at the maternal or the pelvic outlet, where the anteroposterior diameter will be larger. It will be 13 centimeter, and the transverse diameter will be 11 centimeter. Am I clear so far, Sam? Do you have any questions so far? So can you tell me what is the largest diameter of the inlet? You will say the transverse diameter, it is 13 centimeter. Excellent, Sam. Perfect, Sam. So now we will go to the steps of normal labor. Sam, for normal labor, there should be a good uterine contractions and adequate pelvis. If these are there, so the head will undergo a series of movement while passing through the maternal pelvis. It will start by descent, and actually descent is a continuous process during the process of labor. It occurs secondary to contractions and retractions of the myometrium. Am I clear so far? Yes. The next step, Sam, it will be engagement. And engagement, it means passage of the largest transverse diameter of the head. As I told you before, it is the biparietal diameter, which is equal 9.5 centimeter. The largest diameter of the head will pass through the widest diameter of the pelvic inlet, which is usually the transverse diameter, and the head will be in the left occipito-transverse position. So after descent, engagement. Once the head is engaged, it will continue descent till it touches the pelvic floor muscles. Once it touches the pelvic floor muscle, the head here will undergo complete flexion. With complete flexion, the chin will be touching the chest, and this will bring the smaller diameter, which we mentioned before, which is the sub-occipitobregmatic diameter, 9.5 centimeter. This smaller diameter will help the head to pass smoothly through the pelvis. So now descent, then engagement, then increase the flexion. With further descent, as we discussed before, it is a continuous movement throughout the mechanism of labor. Due to the shape and the direction of the muscles of the pelvic floor, the head will rotate into occipito-anterior position. So occipito-anterior, the occiput will be here below the symphysis pubis, and the face will be facing downwards. So descent, then engagement, which means the passage of the largest transverse diameter through the plane of the pelvic inlet. Then once the head reaches the pelvic floor, increased flexion will occur to bring the sub-occipitobregmatic diameter to be the engaging diameter. Then with further descent, the head will rotate due to the shape and the direction of the pelvic floor muscle, so the occiput will be anterior and the head will be in the occipito-anterior position. After that, the head will be delivered by extension. So the only diameter or sorry, the only presentation where the head will be delivered by extension is occipito-anterior position. Any other mal position or mal presentation of the head will be delivered by flexion. So remember again that delivery of the head in occipito-anterior position will be by extension. Any other position of the head, any other mal presentation of the head will be delivered by flexion. After delivery of the head, once the head is free, the head will go into restitution. What is the meaning of restitution? Means the head will realign itself again with the shoulder. So now the face will be facing one of the sides. So this is restitution. Once the head is free and restitution occurs, now the shoulders will reach to the pelvic floor. And due to the shape and the direction of the pelvic floor muscle, they rotate into the anteroposterior diameter, and the anterior shoulder will be hinging below the symphysis pubis. The inside movement of the shoulder is moving from inside, but it will appear outside as an external rotation of the head, and the rotation will be in the same direction of restitution. So again, the head will descend, and the descent is a continuous process through the mechanism of labor. It is caused by uterine contractions and retractions. After descent, we'll come to the next, which is engagement. Engagement means passage of the largest transverse diameter of the presenting part, which is the fetal head, and the largest transverse diameter in the fetal head will be the biparietal diameter, 9.5 centimeter through the plane of the pelvic inlet, and the head will be in the left occipito-transverse position. The next will be increased flexion. Once the head reaches the pelvic floor, the head will be in full flexed position, so the chin touches the chest, and the engaging diameter will be the suboccipito-pragmatic diameter, 9.5 centimeter. The next will be internal rotation. Once the head reaches the pelvic floor muscles, due to the shape and the direction of the pelvic floor muscle, the head rotates into the occipito-anterior position. Once it rotates into occipito-anterior position, this is called internal rotation. The occiput will hinge below the symphysis pubis, and the head will be delivered by extension. And as we said before, extension only in occipito-anterior position. Any other position, any other malpresentation, the head will be delivered by flexion. After delivery of the head, once it's free, the head will realign itself again to the shoulders, so restitution will occur, and the face will be facing one of the maternal sides. After restitution, the shoulders will reach the pelvic floor and start rotating internally. So the anterior shoulder will be below the symphysis pubis, and the posterior shoulder will be down, and the head will show this internal rotation of the shoulder as from outside as external rotation, and external rotation will be in the same direction of the restitution. After that, the posterior shoulder will be delivered first, then the anterior shoulder. In spontaneous delivery, without any aid from the birth attendant, the posterior shoulder will be delivered first, then the anterior. But if there is any assistant, any form of traction by the assistant, you will do downward traction to deliver the anterior first and then the posterior. But in spontaneous labor, the posterior will be delivered first. To make it easier, let's watch this video. So descent is a continuous movement followed by engagement, which means the passage of the biparietal diameter through the plane of the pelvic inlet. Once it reaches the pelvic floor, increase the flexion, so the suboccipito-pragmatic diameter will be the engaging diameter. After increased deflection, and due to the shape and the direction of the pelvic muscles, internal rotation will occur, so the head will be in direct occipito-anterior position. The occiput will be hinging below the symphysis pubis, and then the head will be delivered by extension. So this is the only presentation where the head will be delivered by extension. After that, the head will realign itself to the shoulder, so restitution will occur and the baby will be facing towards one of the maternal sides. Here, the shoulders will start to do internal rotation of the shoulder, will be shown as external rotation of the head in the same direction of restitution. After that, the posterior shoulder will be delivered first in spontaneous labor. The posterior shoulder will be delivered first, then the anterior shoulder will be delivered, and then after that, the trunk and the legs will be delivered bilateral flexion of the spine. Hope it helps to understand more. So again, delivery of the shoulder, we said the anterior shoulder, once it hinges under the symphysis pubis, the posterior shoulder will be delivered first. But if the birth attendant apply any gentle downward traction, he will deliver the anterior shoulder, then it will followed by delivery of the posterior shoulder and then delivery of the trunk. Am I clear so far, Sam? So can you tell me what are the steps? You can use only simple questions. So what's the engaging diameter? What's the descent? What's the engagement? Because again, in teaching stations, the role player is not a medical personnel. So just give him very simple questions. Otherwise, he will take too much time to remember or to answer your question, and he will waste your time. At this point, the foundation year 2 may ask you, so what's crowning? You can tell him crowning is when the largest transverse diameter of the head, which is a biparietal diameter again, distends the vulva, and the head no longer retracts in between contractions. Do you have any questions? Usually the station will be finishing here. So I hope it was useful. How did you find it? Now you are asking your junior trainee about his feedback about the station, how it went, what went well, and what needs to be improved. And then you will provide him with and support him in his continuous training, provide him with articles. Again, please don't be confused. In the teaching station where you have a junior colleague, you will provide him with articles or guidelines. But in a simulated patient task where you will have a patient, you will provide her with a patient information leaflet, also offer him some strat OG videos, and offer him another appointment for another discussion, and if he needs anything to come back and ask you. This is a station, but as I told you in the beginning, sometimes you will face a different situation where you will be asked about abnormal mechanism of labor or any other malpresentation. So just few points. I know it's very basic, but it's very important. And you may be asked and you may feel confused in the station. So presentation means the lowest most part of the presenting part in the pelvis. The most common presentation is 95% vertex, the 3 to 4% breech, and less than 1% the other presentations. What is the denominator? Denominator, it is a bony landmark on the presenting part. It is a landmark on the presenting part. For the vertex presentation, it will be the occiput. For face presentation, it will be the chin or the mentum. For the breech presentation, it will be the sacrum. So this is the denominator, which is a bony landmark on the presenting part. What is the position? It is the relation between the denominator and the fixed point in the maternal pelvis. The fixed points will be the sacrum posteriorly, the symphysis pubis anteriorly, or the sacroiliac joint posterolateral, or the iliopectineal eminence anterolateral. So according to this relationship between the denominator and the fixed point, you can detect the position of the head either occipito anterior, occipito posterior, occipito transverse, or right or left, occipital-anterior or occipital-posterior. Coming to the station, we all know that the station is the relation between the most prominent part or the leading point of the presenting part to the ischial spine, and it will be classified into either 0 station or +1 to 3 or -1 to 3 according to the distance in relation to the ischial spine. As we said, in vertex presentation, the most common is occipito-anterior. 90% of the cases will be in occipito-anterior position. But in some cases, there will be malposition of the head, which is called occipito-posterior. So the presentation is still, it is cephalic presentation, but it is a malposition of the head. So instead of being occipito-anterior, it is occipito-posterior presentation. So in occipito-posterior, the head here will be deflexed. So the problem is in deflection, the flexion of the head. When the head is deflexed in occipito-posterior, this will result in a larger engaging diameter. The engaging diameter here will be the occipitofrontal diameter. The occipitofrontal diameter is 11.5 to 12 centimeters. So instead of the suboccipitopragmatic diameter and occipito-anterior position, it will be occipitofrontal diameter, which is almost 12 centimeter in occipito-posterior position. So almost a 2.5 centimeter increased in the diameter. And this increase in the diameter will make labor prolonged, and it may increase the risk of tears and the risk for the need of operative vaginal delivery or cesarean section. So again, in occipito-posterior position, the problem, the head is deflexed. So the occipitofrontal diameter, which is 11.5 or 12 centimeter, is the engaging diameter. The outcome here depends on many factors. The factors which will affect the outcome include the severity, the efficacy of contraction, the type of the pelvis, and the degree of deflection of the head. So the outcome here, the head is in right occipito-posterior position. So what are the possible outcomes? In 90% of the cases, the head will rotate anteriorly, long anterior rotation, 3/8 a circle, to be in occipito-anterior position, and it will be delivered by extension as usual. This is now long anterior rotation into occipito-anterior position. This will occur if there is good uterine contraction and a flexed head. But if there are weak contraction and the head is more deflexed, we have 3 possibilities. The first possibility, instead of rotating anterior, the head will rotate posterior 1/8 a circle to be in direct occipito-posterior position. So the head will rotate in 1/8 a circle and it will be direct occipito-posterior. Or it may not rotate at all, and this will be persistent occipito-posterior. Or it may rotate short anterior rotation, 1/8 a circle only, and it will become arrested in the transverse diameter of the pelvis, and this is called deep transverse arrest. In deep transverse arrest, the head is mostly, it will be unlikely to deliver vaginally. But in occipito-posterior, direct occipito-posterior, and persistent occipito-posterior with good uterine contractions, you may consider oxytocin and instrumental delivery, and the head will be delivered. But as we said, there is more possibility of operative vaginal delivery, there is more possibility of perineal tears, and more possibility of cesarean section. So this is the case in occipito-posterior position. Before going to the next, I have to explain 2 points here. The head here delivered by, will be delivered by flexion. So the face will be facing anteriorly to the symphysis pubis, and the head will be delivered by flexion. So if occipito-anterior, it will be delivered by extension. But any other malposition or malpresentation, the head will be delivered by flexion. Another point is that you may be asked, by the trainee in the teaching station or by the examiner in a structured discussion, what is a synclitism? First, synclitism means that the head is in neutral position, so the sagittal suture will be midway between the promontory of the sacrum and the symphysis pubis. So the sagittal suture here will be in the middle, and the parietal bones are in equal distance between the symphysis pubis and the promontory of the sacrum. But a synclitism is when one parietal bone is lower than the other one. It occurs due to lateral flexion of the head, either anterior or posterior. So this will bring a larger diameter of the head, and this will delay the progressive labor. So, and a synclitism means the head is presenting by one of the parietal bones. The sagittal suture will be more close to the promontory of the sacrum or to the symphysis pubis, and the head will be presenting by either the anterior parietal bone or posterior parietal bone. So it will be considered either anterior asynclitism or posterior asynclitism. So the examiner here may ask you, which one is better during the process of labor, anterior or posterior asynclitism? The answer here, it will be anterior asynclitism will be better than posterior. Why it is better? Because for the head here to correct itself and to come back in the neutral position, it will pass through a small resistance against the promontory of the sacrum. But for the head here to correct its position and go back into the neutral position, it has to go against the whole distance of the symphysis pubis. So anterior asynclitism is better than posterior. So because it is easier for the head to correct itself in anterior, because it is facing a small resistance of the promontory of the sacrum, but in posterior it will face a large distance of resistance against the back of the symphysis pubis. Now breech presentation. Breech presentation, it will come as a teaching station, either how to deliver a breech, and it may come in the next exams now because it will be face-to-face exam, and you should know what are the maneuvers for delivery of the breech. But here we will talk about the mechanism of breech delivery. So longitudinal presentation, this is longitudinal, and the breech is the presenting part. The denominator in breech will be the sacrum. The bony landmark in breech will be the sacrum. The engaging diameter will be the bitrochanteric diameter, which equals 10 centimeter. It usually enters the pelvis in left sacro-anterior position. Once it reaches the pelvic floor, it will undergo internal rotation. So with internal rotation, the buttocks become below the symphysis pubis. The buttocks or the anterior hip becomes below the symphysis pubis, and now it is distending the vulva. After that, the anterior hip will be hinging below the symphysis pubis, and it will deliver. After delivery of the anterior hip, the posterior hip will be also delivered, and then the trunk will be delivered by lateral flexion. So again, the denominator in the sacrum, the engaging diameter is the bitrochanteric diameter. It enters the pelvis in the left sacro-anterior position. Then it will turn, so the anterior hip will become below the symphysis pubis, and then it will deliver, followed by delivery of the posterior hip. Then the trunk, it will be delivered by lateral flexion of the spine. After delivery of the trunk, restitution will occur, and restitution means the posterior buttocks, once it is delivered, it will become anterior. So now the back is all anterior, and this is a very important. If the baby does not rotate by himself during breech delivery, you will help to maintain the back anterior. This will occur spontaneously, and it's called restitution. Here, after restitution, again the shoulders will engage, and the engaging diameter here will be the base acromial diameter, which equals 12 centimeter. Then internal rotation will occur, so the anterior shoulder will be below the symphysis pubis, and again the posterior shoulder will be delivered first, followed by delivery of the anterior shoulder. Then the head will engage, and once the occiput is below the symphysis pubis, the head here will be delivered by flexion. So again, flexion. So again, extension, the head delivered by extension only in occipito-anterior position, but in any other malposition or malpresentation, it will be delivered by flexion. So this is regarding breech presentation. Another common and repeated question in structured discussion will be about face presentation. Face presentation, again, it is a longitudinal lie. The face will be presenting here because here extension of the head occurs rather than flexion. So in normal mechanism of labor, flexion of the head will occur, so the vertex will be presenting. But here, extension will occur, so the face will be the presenting part. And the engaging diameter here will be submentopragmatic diameter from below the mentum or the chin to the middle of the bregma or the anterior fontanelle, and it is 9.5 centimeter also. The denominator here is the mentum or the chin. What are the possible causes of face presentation? There are many possible reasons, mainly prematurity, polyhydramnios, multiparity, if the abdomen is lax due to multiparity, anencephaly, any tumors in the neck, any multiple loop of the cord around the neck and with contracted pelvis. So these are precipitating factors for face presentation. It can be diagnosed by PV examination during labor. Here you will feel the area between the malar bones, and the mouth. It's forming like a triangle. So you will feel here the eyes, the nose, the mouth, and the malar bones, and the malar bones with the mouth, they are forming a triangle. In face presentation, with descent of the head, if rotation occurs to anterior position and the mentum or the chin becomes anterior, it is called mento-anterior position, and it occurs in 90% of the cases. And in mento-anterior position, the head can be delivered by flexion, again by flexion. So in mento-anterior position, with good uterine contraction and adequate pelvis, the head can be delivered, and it will be delivered by flexion. But the problem will be in the mento-posterior position. In mento-posterior position, there is no mechanism of labor because the chin lies in the hollow of the sacrum. And for the head to be delivered, it needs more extension, and the fetal neck cannot extend anymore here. So in mento-anterior, the head can be delivered by flexion in 90% of the cases, but in mento-posterior, because the head is maximally extended already, there is no way that the head can extend anymore, so there is no mechanism of delivery in occipito-posterior position. We can use forceps for delivery of mento-anterior position, but this will be a senior decision, and after the head is well engaged. But vacuum or ventouse and fetal scalp electrode are contraindicated as it causes injuries. In face presentation, you have to notify the parents for the possible swelling and bruises that may result from the process of delivery. If labor is obstructed or there is no proper descent with mento-anterior, or if it is mento-posterior, you can go for cesarean section. Sometimes you may consider expectant management in early labor. In cases of mento-posterior, 1/3 of these cases, it may rotate and it may be in mento-anterior position and it can be delivered. So this is the face presentation. So the denominator will be the chin or the mentum. The engaging diameter will be the submentopragmatic diameter. The head will be in full extension instead of full flexion. And it can be diagnosed by BV during labor. 90% will be mento-anterior, which can be delivered by flexion. 10% will be mento-posterior, in which there is no mechanism of labor unless in 1/3 of the cases it rotates into mento-anterior. If it is mento-posterior, or if there is delay in delivery of mento-anterior, you can go for cesarean section. The last presentation here is brow presentation. In brow presentation, the head is midway between full flexion and full extension. So it will not be a face and it will not be a vertex. The presenting part here will be the area between the anterior fontanelle and the orbital ridges. So this part is the brow, which is between the anterior fontanelle and the orbital ridges. This is the brow presentation. The denominator here will be the frontal bone. Usually, it is transient. What is the meaning of transient? It means with good uterine contractions, the head will either take the position of full flexion and it will convert into vertex, or it will take the position of full extension and it will be face. But if it is persistent brow, so the engaging diameter here will be the mean to vertical diameter, and the mean to vertical diameter is 13.5 centimeter, which is larger than any diameter of the female pelvis. So labor will become obstructed and there is no mechanism of labor here. So the management of brow presentation, if it is early in labor, wait and see if it converts into face or it will convert into vertex. So you can wait and see. But if it is persistent brow, you have to go for cesarean section because this will be obstructed and there is no mechanism of delivery. Sometimes the baby can be delivered in brow presentation if it is extremely preterm. You may be asked in a structured discussion, or you may be asked by the junior trainee, can we use oxytocin with mal presentation? Yes, this can be considered with caution. If there are poor contraction, especially in prima gravida, it may be used with caution in varus woman, but a point of safety after assessment by the senior or the consultant. So this will be about the station, about the mechanism of normal labor, and what are the different mal positions and mal presentation, and the possible questions that you may be asked in this station. So thank you so much. I hope it was of benefit. If you feel it is beneficial, please share it with your friends, and please remember me in your prayers. I will announce on the group, inshallah, when is our next session. Our next session will be a practical session where we can practice 1 or 2 stations together, and we'll explain in the next time what is the teaching module, and we will take one of the domains, how to communicate with the colleagues. Next session will be announced on the group, inshallah. Again, thank you so much. Please remember me in your prayers. Wassalamu alaikum wa rahmatullahi wa barakatuh.